Hello, my name is Shemra Rizzo. I'm a senior data scientist at Genentech Rush, and today I will talk about our work identifying risk factors for mortality in hospitalized COVID-19 patients in the US. Across the globe, the COVID-19 pandemic placed enormous strain in our already overburdened healthcare systems. Before the pandemic, healthcare demands were already increasingly steadily due to the global population that is growing, people living longer than ever before, and increasing rates of chronic conditions. When the COVID-19 pandemic hit in full force, these challenges were exacerbated. The COVID-19 pandemic also coincided with a pivotal moment in healthcare. On one side, we have data that has grown in volume and complexity, giving us a clear picture of each patient's journey. The technology now allows us for new ways of collecting data and providing care, and advanced analytics provide us with the tools to generate actionable insights that can inform the design of better observational studies as well as improve clinical decision-making. In this presentation, I will describe our efforts to identify risk factors for mortality in American adults who had been hospitalized with COVID-19. A prognostic model like this one has various benefits. For example, identifying patients at risk of the poorest outcomes helps with resource allocation, identifying priority groups for vaccinations, and improving observational studies. For example, those to identify treatments in which you would need to identify covariates to compute propensity scores. This was a big priority for us and the main motivation behind this work. We needed to know what were the most prognostic risk factors for mortality to be used in a study of off-label use of tocilizumab. But the existing prognostic models had a high likelihood of bias due to non-representative cohorts. So, for example, data that came from a single hospital. Also, limitations due to small sample sizes that result in overfitting, and the exclusion of patients that had not experienced the event, in this case death, by the end of the study. So for our model, we use the Optum de-identify COVID-19 electronic health records database, which contains records from hospitals across the US. We identify over 17,000 patients that were hospitalized at some point between the beginning of the pandemic in February and June 5th of 2020 to be eligible for our study. Patients eligible were the patients that were diagnosed with COVID-19 and had a hospitalization within 3 weeks of diagnosis. To be identified as COVID-19 diagnosed, there were 3 pathways in our model. One was a positive test, the nasal swab test, or evidence in the records of an official COVID-19 diagnosis, which are U071 and U072, or the diagnosis that was used as an interim code at the beginning of the pandemic while the official ones were underway. This code was B9729. For the model, the candidate predictors included demographics, comorbidities, many comorbidities that we found in the records prior to the COVID-19 diagnosis. For example, cancer, HIV, hypertension, diabetes, asthma, etc. Also, vital signs that were taken on admission at the hospital, as well as lab results from blood tests that were also taken on admission. Our model also includes calendar time counting since the beginning of the pandemic as a covariate, which we didn't find in other models at the time. And I will show how important this proved to be. For our modeling approach, we needed an interpretable and rigorous prognostic model of mortality. We ran a full model that included all of the covariates, but we also compared its performance to other alternative, more parsimonious models that included, for example, age only or comorbidities only, the demographics or the combination of demographics and comorbidities. Because we needed clinically meaningful results, we used logistic regression for our model. To perform variable selection, we use group lasso with tenfold cross-validation and 100 iterations. Group lasso allowed us to select at once all of the categories in a categorical variable, as opposed to other variable selection techniques in which only some categories get selected. We chose the variables that consistently showed up in at least 95% of those iterations. Whenever we encounter missing data, we use multivariate imputation by chain equations. And as part of interpretability, we needed to gain insights into the nonlinear relationships of some continuous variables and the outcome. Whenever we encounter these nonlinear relationships, we model them using restricted cubic splines. For output, we obtain clinically meaningful odds ratios, predicted probabilities for certain groups, and a ranking of variable importance, which we measure using the chi-square statistic that comes out of a wall test minus the degrees of freedom. Finally, to measure model performance, we use an 80-20 split of training and test set and use C-index and Brewer scores to compare all the models. To measure overfitting, we computed this metric called optimism and found that it was close to 0, which suggested that overfitting was not a problem. Optimism itself is defined as the average of differences in model performance between the training and the bootstrap samples. In this case, we use 50. And finally, we use calibration plots to compare the various models' predicted probabilities with the actual probabilities in the test set. And here are the results. In this plot, we have ordered the odds ratios from largest to smallest, and all odds ratios for continuous variables are based on the change in value from the 25th percentile to the 75th percentile. So in our plot, we see that the odds ratio for age is around 6, which means that the odds of death for a 75-year-old patient hospitalized with COVID-19 is 6 times more than for a 49-year-old, which are the two ages that correspond to the 75th and 25th percentile in our cohort. Calendar time has an odds ratio lower than 1, which indicates a reduction in mortality risk over time since the beginning of the pandemic. A limitation of this plot is that it doesn't convey enough information about the nonlinear relationships. We can see that temperature is mildly associated with increased odds of the outcome, but the story is more nuanced than that. In log odds plots that we have included in our appendix, we can visualize how mortality is in fact higher at both the lower and the higher levels of temperature. And a similar thing happens with systolic blood pressure. In terms of variable importance, which I mentioned was one of the objectives of this study, odds ratios alone aren't sufficient for this purpose because we get one odds ratio per category in a categorical variable like race and ethnicity. But with the wall test that we use, the chi-square metric, we get a single metric for the overall categorical variable, including all of its individual categories. Unsurprisingly, age was the most important variable, followed by labs and vitals taken on admission, which were more important predictors than either comorbidities or demographics. In terms of model performance, calibration curves seen here on top compare predicted probabilities to actual probabilities among the patients in the test set. We can see that the models that included comorbidities tended to be poorly calibrated for more at-risk patients, while the full model was better calibrated. Higher predicted probabilities of mortality were much more common in the full model than in any of the other models, which means that the full model was better able to discriminate between patients. And this is also confirmed in the table at the bottom, where we can see that the C-index goes up from 0.76 for the age-only model all the way to 0.87 for the full model, and similar results for the Brewer score. So in conclusion, we aim to develop a rigorous model that was both clinically interpretable and that had good predictive performance. Compared to other available models, our model had the largest sample size for a US-based model at the time. It had the advantage of coming from multiple hospital networks all across the US as opposed to single centers. The model was interpretable, and we assessed the value of calendar times, something we had not seen in other models. We also provided detailed insight into the role of comorbidities, demographics, and lab results into predicting mortality. We also gained very specific insight into nonlinear relationships. And finally, we confirmed the importance of age as a predictor. Age, it turns out, is nearly as prognostic as all other information on demographics and comorbidities. However, this does not mean that age alone is sufficient for prediction. Vital signs and lab results do improve the predictions. In this plot, we can see the effect of age, that it increased sharply with older age, but also it was greatly reduced by calendar time. So in March 2020, a hospitalized patient aged 80 years old had a predicted probability of death of 34%, but in May, that same patient would have had a probability of death of 20%. In contrast, the predicted probability of death for an 18-year-old patient at the same date was less than 2%. Our model is open source and can be found at the website in the slide. The model we developed could have multiple applications. The most immediate is resource utilization, where care providers can identify patients at high risk on admission and appropriately allocate resources. In our case, we were able to provide useful insights in the evaluation of a potential treatment. Specifically, we used the most important prognostic factors to estimate propensity scores in an external control arm study of the off-label use of tocilizumab. Ultimately, this area of research will enable healthcare providers to make informed clinical decisions, which could improve the outcomes of patients with COVID-19. Today, I describe one example of how we are leveraging data, technology, and advanced analytics at Roche to address challenges in healthcare. Our vision is to move away from the traditional one-size-fits-all approach to healthcare to deliver more precise, evidence-based, tailored, and holistic care. We are applying rigorous analytics to high-quality data sets and utilizing novel technologies to create a continuous cycle of insight generation from bench to bedside and vice versa. Visit the booth at AMLD to find out more about our personalized healthcare approach at Roche. I want to end by sharing links to other work we have developed in response to the COVID-19 pandemic. Thank you.